Now, without further ado, it's my pleasure to introduce Dean Lloyd Minor. Dr. Minor is the Carl and Elizabeth Newman Dean of the Stanford University School of Medicine. He's a professor of otolaryngology, bioengineering, and neurobiology, and has been the Dean of SOM for the last 8 years. Over to you, Dean Minor.
Greetings from Stanford Medicine. I'm delighted to be speaking to a global audience about a subject with such global impact. No matter where we are, we're fighting the same pandemic. But depending on our locations, we're experiencing it very differently. Some are seeing a second surge of cases, and others a third. Some are seeing virus variants racing through the population. Some are experiencing a taste of life in a post-pandemic new normal. Regardless, we come together now to share, to listen, and to learn. We gather now because irrespective of the stage of the pandemic in our own country, we know we are in this together. Last year, more than 2,500 people from 38 countries participated in the inaugural International COVID-19 Conference, producing findings that would be published in the American Journal of Public Health. That inspired event and this return engagement illustrate how the international scientific community has responded quickly and collaboratively to this crisis. So we convene today to share our successes and failures so that we can replicate our victories and learn from the rest. These lessons will ultimately help us put this pandemic behind us and prepare us for the next one. I want to thank Sally Lee, Lata Palaniappan, Bryant Lynn, Michelle Berry, and their teams for putting together a strong program and recruiting such wide-ranging expertise. The collaboration of 4 key centers at Stanford, the Center for Asian Health Research and Education, the Center for Innovation and Global Health, the Center for Population Health Sciences, and the Center for Digital Health, highlights the multidisciplinary task ahead of us. Every day, we glean new insights into this virus and how this pandemic has changed how we operate. Yet there remains so much to learn. I want to discuss 2 key themes that have emerged over the past year: the vital importance of health equity and the crucial role that public health plays in achieving that equity. And I think one aspect of the current fight illustrates the issues perfectly: vaccines. On the one hand, the vaccines represent remarkable scientific achievements, from gene sequencing to shots in arms in less than a year. That's truly historic. On the other hand, despite warnings and concerted efforts to avoid it, the distribution of vaccines within nations and among nations has reinforced existing health disparities. The vaccines themselves are our biomedical system at work. The mRNA technology was years in the making. Scientists spent decades learning more about messenger RNA and devoting careers to it. In the early years of the century, the breakthroughs started coming, though a successful drug or therapy in humans proved stubbornly elusive. Then in 2020, the pandemic hit, and Pfizer, BioNTech, and Moderna were expert enough with the technology to make the next leap, and they succeeded spectacularly. The result is 2 of the safest vaccines ever developed. Even more encouraging is the proof of concept that mRNA vaccines can work, providing a jolt of hope to those battling viral diseases globally. While vaccine development and other elements of the global response provide hope, we must look beyond the past 14 months to understand where we are now. Promising advances in biomedical technologies and scientific breakthroughs have ushered in the era of precision health. The transformative idea that emphasizes predicting and preventing more diseases before they strike and curing them precisely when they do. Despite the ability to deliver precise and proactive care, life expectancy in the United States, which spends the most on healthcare per capita, has declined. In fact, for the first time since the Spanish flu and World War I, life expectancy has decreased for 4 consecutive years in the United States. Across several key health metrics, maternal and infant mortality, rates of obesity and chronic disease, and hospitalizations from preventable causes, the United States has lagged peer nations. Now, that doesn't mean that our healthcare system wasn't delivering excellent care. It does indicate, however, that we didn't provide the same quality care to everybody, nor did we leverage the preventive measures that so effectively are used by public health officials. When the pandemic hit, these health disparities were brought into stark focus. Black, Latinx, and Native Americans are disproportionately affected by the virus. These communities of color are 3 times as likely to be hospitalized with severe COVID-19 cases than white Americans. They also are at least twice as likely to die as white Americans. The United States is not alone with this problem. In country after country, regardless of the type of health system, health disparities exist. The causes and scope differ from nation to nation. And just like with the pandemic itself, I believe we can learn much from each other when it comes to addressing health disparities. This brings us back to vaccine distribution. In the United States, despite concerted efforts to the contrary, a lower percentage of Black and Latinx Americans are getting vaccinated. For example, in California, where Latinx residents make up 40% of the population, about a quarter of the vaccinations have gone to Latinx residents. At the same time, Latinx residents account for more than half of the virus cases and 48% of COVID-19 deaths. This disparity is a product of a confluence of factors: systemic barriers to care, vaccine hesitancy, and an underfunded public health system. And it will require the combined perspectives of medicine and public health to bridge the gap between the two and create a more equitable system. Biomedicine has made extraordinary advances in treating individual patients and even preventing them from getting sick. But too often, this one-to-one approach, while necessary, doesn't scale to address population-level health and wellness. Our nation has for too long had an unhealthy relationship between the medical community and public health. The COVID-19 pandemic has made it abundantly clear that we cannot afford to let that continue. Practically speaking, medicine and public health have operated in isolation in this country for more than a century, with public health often treated as a second-class discipline. By 1994, only 1% of U.S. physicians had received formal public health training. Public health also remains a fraction of our nation's nearly $4 trillion healthcare budget, with funding expected to decrease further by 2023. That is despite well-established evidence that 60 to 70% of the factors that determine our health are social, environmental, and behavioral, issues at the heart of public health practice. And yet, our sprawling healthcare system remains oriented around treating individuals who are sick instead of preventing disease and maintaining health at the community level. To leverage both the public health and medical perspectives, we will need to reimagine our training and funding for public health. Many medical schools, including Stanford, offer public health training through dual degree programs. But this puts too much onus on medical students to volunteer for these opportunities. To ensure a broader understanding and adoption of these ideas, future training must natively integrate public health concepts into the core curricula. Training is just one factor. We must identify the ways to provide financial support to physicians practicing population medicine. Our current payment system doesn't have a good reimbursement model for clinicians practicing public health interventions. Public health provides exciting opportunities to begin eliminating health disparities. Promising work is being done thanks to breakthroughs in big data and AI, digital health, and wearables. The proliferation of digital health tools opens up broader and deeper data sets that provide fresh insights into population health. These advances and others have enabled new fields like biomedical data science to emerge, allowing researchers to better understand human health and target diseases at individual and population levels. The pandemic has made it clear that we'll need a broad array of programs and partnerships to identify solutions that make real-world progress. 1. We should make social determinants a national research priority. We should publicly report the number of research portfolios dedicated to advancing our understanding of these complex and intertwined issues and their health effects and interventions. 2. We should expand opportunities to promising students from underrepresented communities. A diverse physician workforce enhances the cultural competence of care that patients receive and improves access in underserved areas. 3. We must commit to ensuring equitable outcomes and effective solutions to expanding access. We must find ways to build safeguards that constantly work to erode systemic barriers to care. Finally, we must be hypervigilant that medical advances don't exacerbate health disparities. For a glimpse of what this looks like, you need to look no further than today's conference. We have much to achieve to overcome COVID-19, yet that pales in comparison to the challenge of eliminating health disparities. Though the road ahead is long, it is one we must, collectively and collaboratively, travel. The pandemic is proof of what we can accomplish together. We've made history, showcasing the immense potential of scientific discoveries and technological breakthroughs. Now, we must harness this momentum to tackle systemic health disparities. The pandemic is showing us the cost in human lives and national economies if we don't. Armed with an array of tools from precision medicine and population health, healthcare, and public health, we can transform health in the coming years and decades. Thank you.